Hello and welcome to the Common Bridge. This is your host, Rich Helppie. We're glad that you're joining our fiercely nonpartisan discussion about policies to meet the problems and challenges of the day and to seize the opportunities of the moment. Common Bridge is available on most podcast networks. It's available on YouTube TV and, of course, at richardhelppie.com. Please register for free. Today on the Common Bridge, we are again back to discuss healthcare, specifically healthcare and healthcare policy in the United States. And today we welcome the president of Action Benefits, Mr. Karl Albrecht. Karl, welcome to the Common Bridge. So glad that you take some time for us today.
Great to be with you here today.
Mr. Albrecht brings us his experience as an advisor to and provider of employee benefits to many companies. His work in developing technologies to manage the health insurance business in America is probably something that many in our listening audience have actually touched and not known. And he's also had an intense personal medical experience. So, Karl, our audience likes to know a little bit about our guest. And of course, your full bio will be on our website, richardhelppie.com. What were your early days like? Where are you from, Michigan or from elsewhere?
Yeah, I grew up in a small town, same town called Chelsea, Michigan, which is the same town actor Jeff Daniels from and lives in, and family.
Very familiar with that place.
Yep, good people. Runs Purple Rose Theater, so a good part of that community. But that's where I was raised at. Went to Eastern Michigan University. Always kind of knew I was going into the insurance business because that's what my dad had done, more on the employee fringe benefits, which now we call health insurance or healthcare. I started working with a company called New York Life and did that for a number of years, and then had an opportunity to join at my dad's company after a period of time and enjoyed it. It was a great fit. He did more of the retail, had a big book of business, and then we had a real big opportunity that came up with Blue Cross. They'd never worked with independent agents, and this was really kind of looking at the bringing entrepreneurship into not only delivery but service of consumers. And I think that's probably one of the missing pieces that I keep seeing in the healthcare is people are not looking at it from the consumer standpoint. And a few years ago, the catchphrase was consumerism. Then all of a sudden it seemed to swing hard. And now if you see all the marketing, all the technology, all the great, brilliant ideas are all automated call center, computer this, FAQ that. When you start looking at how much people are paying for healthcare and you start thinking what they're doing to them, I think that's probably one of the areas that the movement with health reform has really become an issue for people. And I see it. I do this for a living. I tell that to people all the time. It's like, I do this for a living, and man, it could not be more confusing now. And it's that, you take a look at healthcare and you say insurance companies are unbelievable bureaucracies, and they kind of have to be just by the nature of what they do. But then if you look at it and you say, what's the worst bureaucracy you could ever think of other insurance companies? Well, it's federal government. Well, the two of them got together and they have this new child called health reform. And that's what we're all living through right now. And so it's really kind of in some ways it's working, in other ways it's not. It didn't have buy-in to begin with. So you have one side fighting to the death to stop it, and the other, pushing as a badge of honor that we got to push it through. And it's stuck.
We plan on diving into all of that today. And look, in the interest of disclosure and full transparency, I again want to note, I believe that the era of employer-sponsored healthcare just needs to come to an end. It doesn't make any sense to me and many others that the way people are employed these days and the way the risk pools are formed. So I think we're going to have a great conversation, and I think we're going to really live up to the expectation of the brand promise of the Common Bridge. And that's where everyone will have something to disagree with. Sure. I think we're probably already there, but we're going to have some education and a great conversation. And let's see if we can get to some policy ideas. And Carl, if you don't mind, before we get into your professional life, to the extent that you're willing to share with our audience, you've had some intense personal interaction with the medical system yourself.
Yeah, I had and we're going to make Brian work on his editing. Sorry about that, Richard. So I will go off on a tangent. No, hopefully there's something he can pull
Oh
out of
no,
it for
just
the
you're
sub.
fine.
But,
Listen, this is your show.
but
Okay, you're great.
yeah, I was telling Brian beforehand when we were doing radio, it was like everything had to be just go, and there was no editing or anything. So in some ways it was easier, in some ways it made it a lot more stressful. So yeah, I had a very probably about as bad a diagnosis as you could ever expect to get as a person, I was told 2 years ago, almost to the day, they did biopsies on my pancreas, and they confirmed it was pancreatic cancer. And up until that time, you just knew that that's a death sentence. And I think if you Google a symptom, or you Google really, what the outcomes are for that, it's not good. And so I'm probably the luckiest person you've ever met in your life, just to be sitting here right now. When you look at the statistics, I have a legitimate shot at beating it. I'm not. I have no illusions that I am going to beat it. It's probably 50-50, and for me, that's phenomenal odds compared to what it was. But the only potential cure is surgery. The cancer's, one of its hallmarks is spreading and coming back. That's two really bad characteristics as well. And then it sits in an area that's so central to so many functions that your body performs: digestion, the functionality of your livers. That's typically where it'll go secondary, is liver. It also has a tendency to go to lungs, which is an interesting one. So that whole area is just very challenging. And so the other part that makes it so deadly is so frequently it's caught when it's so far advanced. And that's where I got very lucky. For some reason, it was in an area it created symptoms. And people always ask me what the symptoms, and so I like to share those. The symptoms I had, it just felt like an upset stomach, high up in my stomach, but it didn't change. And it was day after day, it was exactly the same. And about 10 days later, I was like, something's not right here, because usually you go to sleep and it feels better.
Sure.
Yeah, this just didn't change. And so I had a follow up with my doctor for some blood pressure, and I said, something's bugging me. And she sent me for an ultrasound, and they said, it's really inflamed. We can't really see, but there's something there. They did an MRI. They kind of gave me the same thing. And so Dr. Gaith, who was my GI guy, was just phenomenal. He said, you know what? He goes, and I think he knew, looking at my blood chemistry, I think he knew something serious was going on, that something was blocking something, and you wouldn't pick it up unless you had experience in that. And he did the biopsy, and 6 of them were clean. The last 2 showed pancreatic cancer. Now, by some fluke, and this is the part where the healthcare system is kind of interesting, I had already been going to Mayo Clinic because I had some back issues, and I thought, it'd just be, good to be in the system and get a good second opinion. Because back surgery is just so tenuous as well. So I was already in their system, and just by a fluke, it turns out they're literally best in the nation for pancreatic cancer. My brother-in-law, they literally saved his life about 8 years ago from colon cancer. He was 38 and had a very, very large tumor, and they resected that, and he's literally cured. He's doing great. So in my case, again, they can't perform miracles. It's usually not good news. In my case, he said, let's put you on chemo, see what happens. So I did FOLFIRINOX, which is a really awful chemo that for some, again, unbelievable reason, I actually did pretty good with. I never lost my hair. I lost it from other things, but not from that. That was good. I did a second round of another type of chemo. It absolutely beat the hell out of the cancer. I had to stop a couple of times for, this or that, but in general, you just plod through it. The problem I had was some circulatory issues. I have an artery that's not supposed to be where it was. It was in the pancreas, and you learn all this amazing stuff. But one of the other things, the hallmarks of pancreatic cancer, and part of the reason it travels, is it's not really good at developing its own vascular system. So what it does is it finds an artery to attach to and wrap around. And it found this artery that goes to my liver, which should have been out of my pancreas, but was actually in it. And it was wrapped around it. And so the doctor's looking and says, look, he goes, he goes, typically I can take this out. He goes, but in your case, this artery's on top of being in the wrong spot. He goes, it's super narrow. And I don't know if I got enough artery to attach, and if I can't attach it, your liver's gonna die because it feeds half your liver. So, long story short, the chemo was pulled it back from the artery. He was able to do the resection. For some reason, they said they were able to do it. I've developed additional blood flow, which now it's not even an issue anymore. But he had to take my pancreas out because that seam would have been in your pancreas, and he was worried about the digestive juices breaking down that seam. So, long and short, he says, look, you come back every 3 months. We check it. I've gone a year. I go back the end of this month, and the first 2 years are the scariest. They say that's the highest likelihood of it coming back, but we'll see what happens. But the Mayo system is stunning. I mean, it's absolutely stunning. And you look at it from the standpoint of outcomes, efficiency, use of resources. It hits on all those very well. And the efficiency part is it's so helpful to you as an individual that you can have an appointment in the morning, and then they'll fill up 3 more appointments in the day with other areas. And by tomorrow, you know what's going on. By the day after, you're getting treatment potentially for what's going on. And it moves you so quickly, compresses the timelines. You're dealing with the same person inputting it. So again, it's dealing with a system, but it's a much more even integrated system. You see it, that I've seen, and I've been in other parts of the healthcare system as well. And so, really, really well done. I think they kind of take the best of both worlds. The most difficult part, anybody can really get in there. The most difficult part, though, is, can you physically get there for treatment?
They have Scottsdale, Jacksonville, of course, Rochester, Minnesota, and I pray that you will be one of the fortunate few that survive this, because there are miracles done every day within the healthcare system. And when people talk about cost and they talk about reform, they often don't talk about the advances that we've made and the opportunities for cures for things that were unsolvable not very many years ago. And this is something I do think we need to keep in mind, that how do we have a system that can be as good or nearly as good as the Mayo every place? So by way of example, one of our recent guests, Nate Kaufman, talked about the Mayo Clinic and how Walmart was sending their employees that had cancer diagnoses to Mayo, and finding that oftentimes they were being misdiagnosed. So I love the story you're telling about the precision of diagnostics, the integration amongst the various healthcare practitioners, and the very latest in treatment. You're a pretty sophisticated healthcare guy, but you're not a clinician, but you're able to explain what's going on with you. And that's where healthcare should be. Now, Karl, most people get their healthcare through their benefit plans. So you've been doing employee benefits for quite a while now. And so that involves a plan design and employees using the group plan, if I'm not mistaken.
Yeah, it does. And we work primarily with independent agents who work with companies, and mainly in the small group market. So small companies that aren't particularly sophisticated in terms of having an HR department. A lot of times they really rely on their agent to give them the background. and the agent's not an employee of Blue Cross or Health Alliance Plan or Priority. They're independent, and so you're successful as an agent by keeping your customer happy. And to me, that's one of the pieces that is missing in so much of not only reform, but looking at healthcare. It's making sure incentives and people are motivated appropriately. And in that case, that's a perfect description even of capitalism. Is you get paid for giving the client what they want. So your job is to keep them happy. So that works pretty darn well. We work with those agents in terms of developing things like technology. It helps them provide them to the small group provider, but also service backup. You know, they can't be experts in everything, so we end up being the expert in the small group area for them. And they'll come to us with more detailed questions. The basic stuff they know, they know inside and out, and they know, the marketplace, and that's the strength. So, our job is really trying to make sure that those employees are getting the value out of what they're paying for, and the employer's getting the service that they deserve for what they're paying for. Now, the reason that model.
Well, let me comment on that just a little bit, because I've been the employer, and
Sure.
I've been out buying the plan, and it's a difficult game because oftentimes the insurer wants to look at the claim history and then up our premium for the next year based on what happened before. Well, the odds of that happening again are really low, but they're really just trying to recoup their cost of what they had to do to settle our claims.
But they are trying to get you as a client too.
Well, they are, but ultimately, as the employer, I'm not the client, because it's the employees and their families, and all of them have unique needs. And while we offered choice and we offered variety of plans for based on where people were living and what their personal circumstances were, there was always a few outliers that we just didn't have the right plan for certain of our people. And to me, that's one of the downsides of employer-sponsored healthcare, is that I can't meet the needs of all my customers, my employees, and also that every year they have to change. So we have people, the vast majority, very happy with the plan. And then, we have to go put it out for bid again, and we change. And then there's all those games that go on in there. And the information exchange is very difficult, moving, within a plan, and then, among the plans. You've done some things with the understanding the benefits of technology and the benefits of moving information around. And you were quite a pioneer at the time, if memory serves me correctly, or what I've read serves me correctly. I didn't know you then. Tell me a little bit about your take on the benefits of the information technology and the benefits of the information flow from your seat helping independent health insurance agents.
Well, I think, again, you look at an industry that probably is incredibly, where technology can have an incredible impact, is healthcare and insurance in particular. And in particular, when I started getting involved, there literally was no technology, and it's almost funny thinking it was carbon paper and Selectica typewriters.
You're aging yourself there, Karl. Shh, I know what you're.
I know, it's pretty scary, isn't it? When you actually think about it. I mean, the smartest thing I ever did is I took typing classes in high school. I mean, it was absolutely brilliant because you went right onto the keyboard.
Indeed.
But you started looking at these functions, and I'm not a fan of doing repetitive tasks and stuff like that. And you look at it and you go, if I can automate that, it's probably a pretty crappy job to begin with. And it is. They're just like robot type functions that, so it's simple things like addressing labels and things of that nature that we started with, and then it was making sure forms were electronic, so you had records, you could look back. So when you called, and they were all service driven, when you called, I could find your record. I didn't have to go find a file that might be out. I could actually go online. It can exist in multiple places concurrently. And I think that's where the value of, you start looking at the impact you have. And so we looked at technology that not only had an impact on the consumer, but the agent who was required to do the service, and made their job easier, and delivered the ultimate value to all of them. And
Yeah,
so,
you made I think some great points about the consumer-driven side of
right,
healthcare in your opening remarks, and it is an industry that hasn't had to go find a customer, and
right,
it was really passive. In fact, not too many years ago, you didn't exist until you presented at a healthcare facility. Then, oh, who are you? What's your name? What's your address?
right,
What's your insurance? What's your
yep,
subscriber number? So there
yep,
is a improvement. We're nowhere near where we need to be. We think about
right,
what Amazon or your grocery store knows about you and your
right,
buying habits versus what your healthcare
right,
provider knows. Still a long
right,
way to go. But you also mentioned in your opening comments about big bureaucracies. And
hmm,
bureaucracies are
right,
big because they try to fill a lot of roles. And there's
right,
always debate about what's the right role for, a private bureaucracy or a public bureaucracy. So if you thought about the role for the private health insurers in today's healthcare, I mean, what would it be? Are we
yeah,
oftentimes they don't take actuarial risk because they're just administering a plan, but maybe as administrator they're earning their keep. Price negotiator, plan designer, or service provider.
right.
What should we be asking the Blue Crosses and the Anthems and the Uniteds and all the smaller insurers to do today to serve the nation's
Right.
healthcare?
Yeah. And I think you hit the nail on the head. I think it's a great question, because I think one of the things, again, when you look at health reform, one of the things it kept looking at was your cost of doing business and the financing mechanism.
Hmm.
To me, neither one of those are the problem. Those are not going up at double digits. Those are going down at double digit. But that's what everyone's focused on as well. The insurance companies, this, and we need to find it. Even your comments about them looking back. Well, the only reason they're looking back is because they have actuarial tables that you can wipe all that out and just say the feds will guarantee X, and then they don't need actuarial tables anymore. Now they're just pure administrators. The federal government, both Medicare, Medicaid, state government, they hire the insurance to do tremendous numbers of these functions because they're very, very, very good at it, and they're very inexpensive. And so even though they're paid a lot of money, they're doing massive volumes. And I think, that's one of the other things when they start looking at whether it's insurers. I mean, a few years ago, I remember hearing people were talking about, well, do you know how much the president of X company makes? And, X insurance company. Like, oh yeah, he makes a lot of money. Now take how much he makes and divide it by the total number of members per month, and it's like 15 cents a month per member. It's you're not moving the needle. You're focusing on the wrong problem. The problem is the cost of healthcare is going up at double digits, and why is that? And that's what we got to take a look at, is saying, why when the hospital comes back, why when the doctor comes back, and clearly they're having costs increase. So what is so unique that is driving these costs so dramatically higher in those areas? And in my case, there wasn't, I'll give you an example. In Mayo, I had radiation treatment before I had surgery. Um, you can submit that, and which I did, and it's going to take a period of time for the insurance company to come back. And I hate to say it, I'm part of the system. Rightfully, they rejected it. Then the provider put an appeal into and did a provider appeal and said, look, we're doing pretty advanced stuff here at Mayo. We'd like you to reconsider it. They rejected it a second time. And I'm not necessarily saying they shouldn't have rejected a second time. I'm now going to be doing a personal appeal that falls as a member appeal. So, and they may end up rejecting. I'm going to have to pay that cost myself. If you're not in a position to do that, Mayo Clinic may not be an option for you. That's it. It's not, I don't know how to fix that, and I don't know if there is a way to fix that. I'm not sure you want to fix that either, because somebody's going to be taking the lead and somebody's going to be paying, and it may end up being for naught, and that's why the insurance company doesn't pay for it. But that's the role the feds play. They should be saying this should be covered. This should, if you tell me as an insurance company how much, what should be covered, I can tell you exactly what the costs are. I know precisely what they are to the penny. My middle son is an actuary for Blue Cross. He understands this implicitly. I mean, they're very, very good at that. But the minute you start saying that you're taking risk, now I got to calculate that risk, and I have to build in factors for
Yeah,
that.
well, I think so.
You
I
know,
think you're making an argument about some of the downsides of the private insurance. So, and I'll again cite Nate Kaufman's commentary that you know, why is something medically necessary if you're insured by insurer A versus insurer B versus insurer C? It's either medically necessary or it's not medically
right,
necessary.
right,
There's a lot of things that don't lend themselves to coding. You know, the
right,
energy, the age, the overall health versus the
right,
diagnosis and the proposed treatment plan. Um,
right,
but we know that from your own description there that the incentive on the part of that claims paying organization, the insurance company in this case, they want to say no. And they know a number of people will give up on the first no, and others will give up on the second. You're chosen to persevere. It seems like it's a rather cruel place to put a person that's already got their hands full. And
yep.
the reason the insurance company doesn't have the right economics is because we don't have enough people in the pools. I mean,
Right.
insurance
And
is
and and I,
all
I love the statement. And the way you framed it, that sounds correct, but it's incorrect. And I think part of it is this: when you look at the make sure I get my statement right. And I like the fact that he's editing this because I gotta get this point correct here. Um, the they're on the front edge of treatment. So insurance companies don't pay for experimental, they don't pay for research, they pay for proven services. So, but there's no one group that says what it is and what it isn't. And that's where I think the feds can say that is this is covered and this is not. Now you fight insurance companies over who's best administering this coverage. The feds aren't very good at that. The feds are terrible at that. So the feds need to be setting the rules and being umpires versus being umpires, players, judge, jury, which is what they're doing right now. And I think that's what creates part of the problem. So the insurance company itself, in terms of having it paid for, if the federal government was looking at that right now, I had the ability to appeal it. The answer would be no, period. Periods. Now that relieved me of any stress of having to think about it anymore, but I was able to get it done. And I think, or I'm hoping I'll get it done, but at least I had the treatments. But if the feds run it, the answer would be absolutely no, because one size fits all is how the feds, and that's why there's so many departments and so much. We got to be fair.
well,
We got to make sure everybody's treated exactly the same.
but let me react to that. That
Yeah,
if the feds are saying what's in and what's not in, then in
right,
effect there is no appeal because it lets one bureaucrat point to another bureaucrat and say that's not something we're going to do. And one of the, I think, flaws in the Patient Protection and Affordable Care Act, also known as Obamacare, and we'll get to talk about that in just a minute, is that there was not differentiation among plans because it was all dictated
right,
and prices were
right.
dictated. And with
Mhm.
no market differentiation, you're not letting the consumer make choices for that consumer's situation.
Yeah,
So um, I don't know that moving everything to a federal platform or in fact giving them the rule book and letting them make the call is the right way to go at all. But I think you also make an important point. Most people in health that aren't in healthcare don't understand what a fiscal intermediary does. So that when you're
right,
submitting a claim for Medicare, for example, it's going through an insurance company who has the ability to process the claim and pay the claim. Okay, that's
correct.
what a fiscal intermediary does. Um, and uh, I think nobody would dispute that the insurance companies are really good at paying medical and hospitalization claims. Now,
Hmm.
pharmaceuticals, not all that good at this point, and that's one of the flaws there. But at a broader level, Karl, policy level, does the tax favored treatment of employer sponsored healthcare make sense today?
Well, the last thing you want to be doing is making healthcare more expensive right now. So it doesn't seem like taking that away. I think one of the challenges you try to do is find ways to um, try to consolidate, aggregate business, and at the employer level, that's been a good place because you're getting the Social Security information, you're going over the other benefits. I want to attract employees to my firm by giving good benefits. Is that legitimate? To me, I think it is to say I'm going to give better benefits and better vacation policy.
All right. Well, let me unwrap that just for a second. So you and I are neighbors. Okay, we live right
Yep.
next door to each other.
Yep.
And your employer, in fact, let's just say we're in the same apartment building with the exact same floor plan, paying the exact same rent. Okay.
Right.
And I work for employer B and you work for employer A. And your employer says, we want to really give a grand plan and it costs $25,000. And that's your employee benefit. And you pay zero tax on that compensation. And my employer's a little tighter. And they say, you don't need that much. And I get a very skimpy plan that costs $12,000. Okay.
Right.
You just got $13,000 of tax-free money where I have to go into the market and make up that difference. And to your point about adding cost, what I would propose is this: we tax those benefits like the compensation they are. And I'll say that on two. Let me say this on. I think that would be, if there was one change you could make in healthcare, I'd tax the benefits today. And here's why. All right. First of all, that provision in the tax code was only spawned out of wage freezes in the mid 1940s. And employers couldn't give raises. So instead, they offered benefits and they got that tax break. It's never gone away. Well, the world's changed a lot since that time. But also, let's go back to that example. You've got the $25,000 plan and I've got the $12,000. Now you're on your W-2, here's $25,000. You're going to go, whoa, wait a minute. Why do I have a $25,000 bill? Oh, well, Karl, you're paying, first dollar on primary care. You're paying for this network. You're paying for these specialized services. You're probably going to go, wait a minute, take that out. Okay. Yeah. And now we start getting medical inflation worked out. Let me give you the last word on that because we've got a lot more to cover today.
So now your diabetes is not being treated, your high blood pressure isn't being treated, and your circulatory issues aren't being treated. I don't know how you're saving costs, and I think that's
I think that argument. If my employer came to me and said, the reason your health plan costs $25,000, it's because we're treating your blood pressure and your diabetes, at a price point that you can't get because we pulled the risk. I'm like, okay, that makes sense.
Right.
But but I would probably ask, well, what could come out of that plan that I shouldn't be paying for?
Yep, and there's not too many options left. I mean, under Obamacare, they pretty much have established, and I don't think that's necessarily a bad thing. Again, because we're looking at what's driving healthcare inflation, and it is going up at double pace, and it's drugs, it's high blood pressure, it's diabetes, it's all function of the society we live on, but I think what people don't understand is our healthcare system also is unlike almost any other nation in the world, fully absorbs the social ills that are pretty unique to this country, and they show up in the emergency room. And you look at other countries. I mean, you don't have anything like this. And for every shooting you have where someone's murdered, there's probably 20 people that survive getting shot, and that is not cheap.
There is now of the shootings, which we've talked about on this. 2/3 of them are suicides, and there's the debate. would that those deaths occurred absent a firearm? We don't know. Or
Right.
would people be injured with an unsuccessful suicide and
Right.
then require care? I'm not aware of any um, economic study of that at all. Uh,
Right.
but since we opened the door here talking about um, the Obamacare Patient Protection and Affordable Care Act, and that it does mandate much of what goes into the healthcare system, what are some of the top two or three positives that you've
Mhm.
seen from the Obamacare Act of 2010 as it's amended today?
Yeah. I would say, to me personally, and a lot of people would be kind of shocked by this, but the medical loss ratio I really like, and it by federal law requires that a insurance company spends 85 cents every dollar on patient care. And there's things that go on in and around that, but in general, you got to run everything from marketing to contracting to billing, and I think that's what I was talking about. Insurance companies are very good at it, but that's also driven consolidation because now it's just a function, and the more efficient you are at doing that, the better. But the temptation is to stop giving service now because that's just a cost
Yeah.
item. And my concern is that service is becoming a form of underwriting. If you need service, you might have some health issues, and therefore, by not providing service, I am deflecting you to someone else.
Okay. And what are some of the negatives regarding the Affordable Care Act?
Just dramatically over promised, and did not. It was. I think there was enough energy to do a bipartisan deal, and it wasn't, and which doomed it long term. But we were all supposed to. I mean, the comments were made. You're going to save $2,000 a year as a family. You're going to be able to keep your doctor. It's people's costs went up significantly. Their deductibles went up. What the government didn't tell you was you're going to save a lot of money, but they're going to keep the savings. And that's how they're going to try to cover additional people. But the whole thought of telling a 27-year-old kid that you should be paying as much as a 58-year-old person who's been smoking and drinking and not working out their whole life is insane. And that's part of what was put in place was a structure. It was more, it hit too many political buttons and not enough basic suck it up logic business. This is, someone's going to lose, and you just got to make some of the decisions. And I think that's something that I am trying to point out. It's like, I don't want to say any changes in the system are wrong whatsoever. Just be aware that they're not a panacea, and what you're giving up. And it's kind of like capitalism. It's, again, it's got problems, but I haven't seen anything any better than that. And in our case, we're spending a lot of money. I think there's some pretty simple things that we can do going forward. Hopefully we'll start doing those.
Yeah, and look, I've been deep into this, and um, the shall issue rules I think were very very helpful. Um, when they talk about more people covered, what we've really done is we've expanded Medicaid, higher income point for able-bodied adults with no children who used to not be able to get Medicaid. Um,
Right.
and we know that people that get Medicaid in a well-administered plan do get their preventive care. Again, I
Right.
think a step in the right direction. And Medicare for people that get to 65. But we have this vast problem in the middle, and that is
Mhm.
people that are not yet eligible for Medicare and are
Mhm.
doing too well to be on Medicaid, and particularly
Right.
if they're gig workers or independents, they're
Right.
stuck having to
Right.
buy a mandated policy, to your point, that might be really appropriate for an older person or a person that hasn't taken care of themselves, and they're bearing all that cost. It could be
Right.
for a single individual, $600-700 a month, and then a
Yep.
12 or $15,000 deductible. That's a heavy lift. And when people talk
Yep.
about the cost of healthcare, this is not anything mysterious. It's this simple. How many people are there? times how long do we live, times how much stuff can we do, times how often do we do it. And it's not about unit cost, but that's the multiplication right there that comes out. That's the cost of healthcare. And actually, the number one thing driving the increased cost in healthcare is we're living longer. And as we live longer, we're now past the point where cardiac events used to kill us. They don't. We get cancers.
No.
Stroke care is so much better. People survive to get a cancer later. So it just plays into that. How many people, how long do we live? And then to many of your early points, there's new technologies and treatments coming on board. Oh, that's more things we can do. That's more cost, more, and then how often do we do it? So that's the simple cost line. And I have recommendations on healthcare, and we've had Dean Clancy on who talked about health savings accounts for everyone. We've had Brian Peters on from a national policy view. We've had Rob Caslew, who runs a major health network in a multiple state area. And of course, Nate Kaufman on a couple times. Chris Allen coming from a public health view and taking care of people in real need. And we all kind of come around to what we think healthcare insurance ought to look like today. What's your view? What would you recommend that the healthcare insurance policy of the United States would be today?
If you don't mind, let me just talk on that Medicare point for a minute. If I can drop back to that, and again, we'll let Brian do his editing on that. I think one of the concerns I have about Medicare is you have tremendous numbers of people that retired in 1995, and they're getting 2021 care.
Mm-hmm.
Where did that money come from? And I think the problem is politicians are not being honest with people and saying, it's expensive and you're not going to get everything. And we need to make some pretty tough decisions on some of that. I remember a few years ago, a new drug came out for macular degeneration, which was an injection into the eyeball, and it was literally like $100,000 per year. And there was 100,000 Medicare patients that would apply. It would bankrupt Medicare. What do you do? If you don't get these injections, you might go blind. But what do you do?
Well, I think
tough.
Your personal situation, I think, speaks volumes to that. And then everybody says, well, we only want proven, effective therapies. Sounds good, right?
Sounds real good.
What is it before it's proven? Somebody comes up with a better mousetrap. By definition, it's unproven. And that, going way back, that was one of the chief issues with the Clinton Care bill, in that it basically wanted to freeze everything in place at 1992, which is ancient history in medical care today. And because that was the way they were going to shut out that third item on that cost line of how many things we can do and how often we do that. The real savings is, as you've hinted at, it's in personal care. Are we eating right, not smoking, exercising, sleeping, stress-free as much as possible? And again, I'd encourage everybody to listen to the episode with Chris Allen. I want to say it's episode 35, but I wouldn't go that far. We have ways to get people healthy versus taking care of them when they get sick. And that's what I feel. And look, I will tell you what my view on healthcare policies, we should take all the tax-supported systems, Medicare, Medicaid, TRICARE, VA, put it in one system, one bureaucracy. If you're a United States citizen, you get it. And if you're a taxpayer, it's a percentage right off your 1040 that goes to pay for that program. Second item, if the employer wants to offer an additional policy above and beyond that, they can do that, but the cost of its compensation. And I would let there be a private market for people that want to go buy
Right.
additional coverage. Perhaps you're buying access to the Mayo Clinic, or
Right.
Sloan Kettering or Cedar
Sure.
Sinai or some other group that says, yeah, they'll take some of those higher risk patients, and then you could sell that as an insurance, and then you
Mhm.
you 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 wouldn't give up the innovation aspects that have made American healthcare a place where miracles do truly happen every day. We've got the financing side of it messed up as big as you can mess it up, but
Yeah.
we have great doctors and hospitals and clinics in the country. So Karl, when you think about the best policies and things you'd like to see change, I don't know if this is even a good question, but what's the greater risk, that just inertia, doing nothing, or a bad policy approach? Or is there, if you said there's two things you could change about the healthcare system today, what would they be?
Yeah, and to me, we just can't afford to make another mistake, and that was the problem I had with Obamacare. It was like, this has to be bipartisan, so figure out a way to sell it. You have to do it that way, or it's doomed. And we've seen that, and because we know what's going to happen out there, and so a small number was able to do a lot more impact. When I look at the healthcare system again, I think um, the insurance companies have been the bad guys, and I think if you really step back and look at the bigger picture, it becomes pretty intuitive that the bigger picture is a lot different than that. A doctor, a hospital, I mean, their pen can write millions and millions and millions of dollars it costs. And how many times have clinics, you find out the spouse is running a separate clinic, their referrals are going into, and so there's a lot of protection on that needs to be there. Is it medically necessary? And so I think that type of stuff has been left to insurers. If you start looking at taking over some of that more federally, it's real easy to not, they did the same thing with drugs. The drug issue is, you say, look, we'll give you the opportunity to write everything off instantly, but you got to drop your patent. Give them something to think about, or we'll give you an extended patent if you focus on these drugs, which you have a stronger community need. There's ways to do that, and it's just the shouting has gotten out of control. But if you look at the insurance company, you say they are the only one who has got any leverage to negotiate with a doctor or hospital. A patient sure doesn't, and the insurance company does. And so, but the balance to that is the insurance company's got to keep you at least happy enough as a customer that you come back. Otherwise, you're not worth anything to them staying a year. You have to stay a period of time before you're worth something. The game getting played at larger companies is a total different deal than what's going on at the smaller level. So, really kind of a different functionality. But ultimately, I think the government needs to grow up and needs to tell people you're not going to get everything. Healthcare is like outer space. It goes on forever and ever and ever. And I guarantee you, I could look at you in 10 minutes, come up with a whole bunch of stuff that we medically could do, but does it have any value, patient value? And I think that's part of where it's hard to get around that. And then you look at the patients or the individuals and you say, some could not care less if they go to the doctor down the street, and some want to go to Cleveland Clinic. Everybody's different. If you worked hard your whole life and you want to spend it on healthcare or food or travel, that's your choice. So if you're able to restrict it, but if you look at some of the other countries like Britain, they tie barred the healthcare system together so that you didn't create two different systems, and that's what the concern becomes. If you allow people to buy separately, you end up with two different systems. So I do have a lot of, insurance is protection against unforeseen risk. Right out of the blocks, we know that you have basic healthcare functions that should just be paid for and should just be part of a normal. And again, the feds make data requirements, which you saw a lot of that change. It really drives innovation. So the government can really step in key spots and go, here's the rules. And the insurance companies will come right around and follow those rules. So whether it's, we'll back up the underwriting on this, therefore now your risk is totally gone, so drop the price. And you do that at the time. If you want to start taxation, you do that shift all at the same time. but it's got to be bipartisan. It has to be
Well,
bipartisan.
let me first of all support your view on bipartisanship, and being fiercely bipartisan is what the Common Bridge is all about, and getting people to talk together and trying to solve the problem. And at the top of this interview, we talked about everybody should get the kind of extraordinary medical care that you're receiving, and
Yep.
leading hopefully to an outstanding outcome. That's the goal, and to do it at an
Yep.
affordable price. And that both of those are achievable if
Right.
we continue to actually focus on the problem. But
Yep.
today, there really is no constituency for telling people let's grow up and act responsibly. Um,
Right.
there's a lot of constituency out there for someone else should pay for it, and you should just get whatever you
Bingo.
want. Um,
Yep.
I can tell you that this is from years ago, but I was behind a woman in a pharmacy, and she's on the phone, and she said, "Hey, I'm at and these prescriptions are bagged up." And she said, um, "Neither Medicare or Medicaid will pay for grandma's cough syrup.
Mm.
Do you still want me to get them?"
Mm.
Okay. I
Yeah.
mean, if it's free to that person, I'll take it. But if, it's a question if I have to reach in my pocket and pay for
Right.
it. And to me, that really
So
sums up the issue right there.
so 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 now look at this. So look at how crazy the healthcare system is that has forced you to look down to something that's $7.99 because we're not handling the diabetes on the other side of it. Okay. I mean that's so obvious to me that you're diminishing returns on going after something like that is obscene. When you look at the other end of it, that if you just stopped one diabetic, you just wiped out that whole community's cost of cough syrup for the year. You see what I'm
No,
saying?
no,
So,
well,
so
look,
that's
I think, look,
there's
the paying for covered lives, and there's
right,
been various forms of, like, capitated payments now for years. The Medicaid systems are doing a good job of this, about managing the disease versus
right,
reacting to the symptoms, and trying to
right.
get those ER visits down. Karl, a question I ask all my guests, or nearly all of them: has there been any change to the issues or your thinking or theories since the onset of the pandemic? Has the pandemic changed anything for you?
I think I've been a big believer in technology and healthcare. So again, you need to have people where there needs to be people. You need to have technology when there's technology. So I think one of the things the pandemic did is it shifted so many people that were reluctant to embrace technology as a communication platform. Large numbers have embraced that, and for medical purposes, because they had no choice. There was a period of time when I was getting treatment where nobody would see me.
Mm.
And then there was a period of time when I couldn't get the vaccination and I had to go get treatments done, and I have to be in a room full of cancer patients. And so that was pretty frustrating. So again, you look at logic, the government's not immune to making dumb decisions too. And so
That's an
I
understatement.
think we need to be, I think we need to be aware when when we look at ceding control of government, it tends to be one way. And I'm not an anti-government. They have a critical role, not only in the financing but setting the rules, because the buck has to stop
Sure.
somewhere. But they just can't cross that line until they put their thumb on the scale, and that's what they're doing right now. And I think that's what they need to get off of that and come and be honest about it with the people.
Great. Karl, this has been a great conversation. I've really enjoyed having you as a guest. Um, what didn't we cover today, but maybe that we should have covered, or any closing thoughts that you've got for our audience on the Common Bridge?
Yeah, I don't know if you put this in or not, but my situation with pancreatic cancer, you can't follow what I did and get the outcome I did. It is honestly a miracle. And when I look at where I started this, is I can't come to any other conclusion that there was some other intervention in this. But my point being is I don't want to give false hope to people. But the flip side, and I'm part of a pancreatic cancer group on Facebook, and it is the most depressing thing because the outcomes are so terrible that I feel I need to speak up to say there is, some of us do get somewhere. And I don't know if it's going to keep going, but I've got 2 years since diagnosis, and that's a miracle. And 2 guys I've worked with, one from my hometown passed away. He was just it was just diagnosed in December, and another guy was a friend of a friend, which I can't believe. Going to the same doctor as I was at Mayo, and he just passed away about 3 weeks ago. So it's even when people talk about Alex Trebek, I mean, he was terminal. They just had him somewhat under control, so he was not a good comparative for people to look at, because he was not going to walk out of that alive. So, my point is I want to make sure that people understand that this is, the thing I always used to compare it to was March Madness. Is you lose one, you're done. That's it. You have to win every single one all the way to the end, and you look at those odds, and that's what you face. And but somebody's going to make it.
Karl, you're a brave and forthright man, and pancreatic cancer has touched my life with family members, close friends, business associates, employees, and it is one of those diseases that I hope that our children or grandchildren look back on and go, yeah, we used to have that, and we, through the grace of God and through the miracle of modern medicine and through all the incredible medical technology and people that are serving healthcare, that we do come up with a cure. And I hope and I pray that you will be the next one on the cure list.
Thank you.
This is Rich Helppie today on the Common Bridge with our guest, Karl Albrecht, talking about healthcare, talking about his personal journey, talking about the role of private insurance, talking about his experience trying to serve customers, make sure they're happy with their healthcare and healthcare insurance. You can read more about Karl at richardhelppie.com. And when you're there, please register for free. We'll see you on YouTube TV at Richard Helppie's Common Bridge channel, and on podcasts wherever you get your podcasts. So with our guest today, Karl Albrecht, this is Rich Helppie signing off on the Common Bridge.
Thank you for watching Richard Helppie's Common Bridge. Please click the subscribe button below. Also, tune into our podcast, Richard Helppie's Common Bridge, on Apple, iHeart, Amazon, and others. Also, be sure to visit us online at richardhelppie.com.